All right, so it's my pleasure to introduce Dr. Megan Coriell. Dr. Coriell graduated from the University of Louisville School of Medicine. She did her pediatric residency at the Medical College of Georgia in Augusta, and then, of course, followed that with Pediatric Endocrinology Fellowship at the #1 fellowship program in the country, right here at the University of Louisville. And we were fortunate enough to recruit her, and she has been a fantastic faculty member on our team since 2023. Has it literally been that long?
Yes.
We're all getting older together. Not an interesting tidbit about Dr. Coriell's background is she did minor in theater when she was in college, and so that has served her well as one of our most prolific educators. She has spoken on a wide array of topics since she joined our faculty, and I'm excited to hear this one, which is about hypopituitarism, a journey, not just a diagnosis. Please welcome Dr. Coriell.
Thank you, Dr. Winterger. All right, so we are going to dive right in. I don't have anything to disclose except there is a lot of information in this talk, so just buckle up. Hopefully, I think it's going to be a really good lecture, especially for our fellows. This lecture kind of came about because we've had a lot of young adults who have needed to transition from our clinic to the adult clinic. And so we've had a lot of questions about, well, how do we best help these young adults as they're navigating this transition? And what things do we need to be looking for that we don't necessarily look for in our younger kids? We've actually had a lot of young adults with hypopituitarism making that transition. So today we're going to review hypopituitarism, including definitions, diagnosis, and treatment. We'll explore the differences and similarities between hypopituitarism in pediatric versus adult patients. And then we'll discuss transition of care for patients with hypopituitarism from pediatric to adult providers. So what is hypopituitarism? So this word is really an umbrella term. So it is refers to a deficiency of one or more pituitary hormones. But under this umbrella, you can further define it by several different features. So one feature you can define it by is hormone deficit count. So you can have isolated pituitary deficiency, which refers to one hormone deficiency. We see this a lot in pediatrics with growth hormone deficiency. You can have combined pituitary hormone deficiency, which is two or more pituitary hormone deficiencies. And then panhypopituitarism refers to deficiency in all the pituitary hormones. This is how it's defined in the medical literature, although I know a lot of times in everyday life, we often refer to really anyone with two or more as having panhypopituitarism, but in the like research and literature, these are the definitions. So you can also define it by biological origin. So primary refers to damage to or disorders of the pituitary gland, whereas secondary refers to damage to or disorders of the hypothalamus or pituitary stalk. And then you can also define it by timing and etiology. So congenital refers to it being present at birth, often due to genetic mutations or development issues during fetal growth. Acquired refers to it being developed later in life, usually due to external factors. And then idiopathic, meaning we have not determined what the exact cause is. You can also have permanent and progressive versus transient with potential recovery, and we'll touch on that a little bit. So this large, very full chart goes through all the different causes of hypopituitarism, both in pediatric and adult patients. And you'll see that there are quite a few overlaps, but there are some specific things for each group. For pediatrics, the most common cause is congenital causes. So that can cause anywhere from 39 to 61% of cases. And that includes genetic defects, developmental abnormalities, central line defects, all of those things. We see a lot of kids with septo-optic dysplasia. And then for adults, the most common cause of hypopituitarism is pituitary adenomas. And the literature I read said that it accounts for approximately 50% of cases. In both age groups, different types of tumors can cause hypopituitarism. In kids, craniopharyngiomas is the most common brain tumor, and it actually accounts for 6 to 13% of intracranial tumors in children. Both patient populations can have hypopituitarism from traumatic brain injury, and this is often the category we think of as something that could be transient versus permanent, and a lot of times it's something that evolves over time. We can see inflammatory or infiltrative diseases cause hypopituitarism. One of the ones that we come across relatively commonly is Langerhans cell histiocytosis. So oftentimes this presents as AVP deficiency in pediatric patients. And so they'll fail a water deprivation test, then we get the MRI, and then we find that. For adults, they can have lymphocytic hypophytis, which is actually something that we falsely ran across in a patient here recently, in a pediatric patient. So I thought that was interesting. And then infectious causes can also lead to hypopituitarism. Vascular causes are a lot more common in adults. But we can see pituitary apoplexy in pediatrics. And I actually have a young lady who had pituitary apoplexy. I think she was diagnosed at like 15 or 16 years old. Sheehan syndrome is something that can be seen in the adult population, and that refers to postpartum pituitary necrosis. And then, of course, medications can cause hypopituitarism, both transient and permanent. All right, so this is our lovely pituitary gland. I really liked this picture because I think it's very colorful, and so it helps kind of delineate all the different hormones and where they come from. So as we know, we have our anterior pituitary gland that makes most of the hormones. We have our posterior pituitary gland, which stores hormones. And then we have our pars intermedia, which is where MSH is made. So we'll go through each of these hormones and kind of review what they do. So we'll start with ACTH. So ACTH is made by corticotrope cells in the anterior pituitary gland. It's released in response to stress, light and dark cycles, and corticotropin-releasing hormone from the hypothalamus. ACTH and cortisol are both released in pulsatile circadian rhythms, so they're highest in the early morning. ACTH has a lot of functions. Its main function is to stimulate cortisol production. So it binds to melanocortin 2 receptors on the adrenal cortex, which triggers conversion of cholesterol to cortisol in the zona fasciculata. It also regulates adrenal steroid synthesis. It does this by upregulating steroidogenic enzymes and proteins. It increases cholesterol uptake and synthesis in adrenal cells, and then stimulates production of adrenal androgens. And then another important thing that it does is it maintains adrenal gland structure. So it promotes adrenal cell growth and development, as well as increases adrenal vascularization. And so this is why when we have high ACTH levels and chronic stimulation of the adrenal gland, that we can get adrenal hypertrophy and hyperplasia. ACTH is regulated by a negative feedback loop. So here in A, this shows a normal, non-stressed HPA axis. So the cortisol will negatively feedback the pituitary and hypothalamus. B shows the normal function of the HPA axis under stress. So essentially stress cytokines that further stimulates the hypothalamus, which leads to increased stimulation of the pituitary gland, and then ultimately increased stimulation of the adrenal gland. We still have negative feedback in that situation, but the stress, that stimulus overwhelms that negative, or overrides that negative feedback loop. And then in C, this is an insufficient HPA axis. So it shows where there can be problems in all areas. So we can have problems with the hypothalamus, the pituitary gland, which is what we're focusing on today, and then the adrenal gland. A problem anywhere in the HPA axis, as we know, leads to low cortisol. All right, go back to our pituitary. All right, so now we'll talk about growth hormone. So growth hormone is made by somatroph cells in the anterior pituitary gland. It's released in response to growth hormone releasing hormone and ghrelin from the hypothalamus, and it's inhibited by somatostatin. It's secreted in pulsatile fashion with peaks mainly at night. So when we tell kids that they grow the most at night, it's not us just trying to get them to go to bed. We know that growth hormone is highest at night. Growth hormone has a lot of functions. The one we think of the most is that it stimulates linear growth in children. It does this by binding to growth hormone receptors on the liver, cartilage, muscle, fat, and kidney tissue. It triggers the JAK-STAT signaling pathway, which stimulates hepatic production of IGF-1. And then both growth hormone and IGF-1 act directly on growth plates to promote bone elongation. Growth hormone is also very important for metabolism. So it stimulates the breakdown of fat in the adipose tissue and promotes protein synthesis throughout the body. It also antagonizes insulin action. So it increases hepatic glucose production and decreases glucose uptake in muscle and adipose tissue. So it's a very important hormone to help prevent hypoglycemia. And then and it has an important role in maintaining body composition in adults. So it regulates muscle mass and strength. It controls fat distribution and adiposity. And then it supports cardiac and organ function. And this is actually one of the things we do talk about with our pediatric patients, is that growth hormone is not just for linear growth. It also supports cardiac muscle strength, bone health. So there are a lot of important benefits to it if you have growth hormone deficiency. Although linear growth is the most benefit we see out of it, there are other important things that it does. So growth hormone is also regulated by a negative feedback loop. You can see here, so IGF-1 goes back to inhibit the anterior pituitary and the hypothalamus. And an important thing to note is that growth hormone secretion decreases with age and obesity. And so with the increasing prevalence of obesity, we do have to keep that in mind with pediatric patients, that we can falsely diagnose someone with growth hormone deficiency due to their obesity. And so we just have to keep that in mind. All right. So now we'll talk about thyroid stimulating hormone. And this is made by thyrotrope cells in the anterior pituitary gland. It's released in response to thyrotropin releasing hormone from the hypothalamus. Its main function is to stimulate thyroid production. It does this by binding to TSH receptors on thyroid follicular cells, which triggers the synthesis and secretion of T4 and T3. It also regulates thyroid gland structure, so it promotes thyroid cell growth and development. It maintains thyroid gland size and vascularity, and then it helps maintain metabolic homeostasis through the production of thyroid hormone. Thyroid hormone is important for regulating metabolism, growth, brain development, body temperature, energy production, and so very important hormone. TSH is also regulated by a negative feedback loop. So T3 and T4 go back to inhibit the pituitary and the hypothalamus. An important thing to note is that TSH has a log linear relationship with T4 levels, which means that a small change in thyroid hormone can lead to large changes in TSH. And this makes TSH the most sensitive marker of thyroid function. All right, go to LH and FSH. So these are made by gonadotroph cells in the anterior pituitary gland. They are both glycoprotein heterodimers. They have a common alpha subunit and a unique beta subunit. They're released in response to gonadotropin releasing hormone from the hypothalamus. And GnRH is released in pulses every 60 to 90 minutes. The speed at which those pulses are sent actually favor one versus the other. So faster GnRH pulses favor LH secretion, whereas slower pulses favor FSH secretion. Here in this chart, I have the different functions of FSH and LH in females versus males. So FSH in females stimulates growth and maturation of ovarian follicles, promotes estrogen production by granulosa cells, and is important for recruitment of antral follicles each menstrual cycle. LH in females stimulates the theca cells to produce androgens and triggers ovulation via the mid-cycle LH surge. It also supports the corpus luteum formation and progesterone production. And then it maintains the luteal phase of the menstrual cycle. For males, FSH is important for spermatogenesis by stimulating the Sertoli cells, and it stimulates production of androgen binding protein. LH stimulates the Leydig cells in the testes and promotes testosterone synthesis. Testosterone then supports spermatogenesis and male secondary sex characteristics. These hormones are also regulated by a negative feedback loop, which is a little bit more complicated than some of the other hormones. But LH and FSH go back to inhibit, the estrogen and testosterone go back to inhibit the pituitary gland and the hypothalamus. Prolactin is made and secreted by lactotroph cells in the anterior pituitary. It's also produced in extra pituitary sites. Its secretion is pulsatile and peaks during sleep. And it is different from the other hormones in that it's under tonic inhibition by dopamine. So it doesn't really have a classical endocrine organ target. So there's not a traditional feedback loop. Instead, it has a short loop feedback. So prolactin stimulates the hypothalamic dopamine release, which then inhibits prolactin release. The main function of prolactin is for lactation. So it stimulates mammary gland development during pregnancy and milk production postpartum. It works synergistically with estrogen, progesterone, insulin, and cortisol. It has a reproductive function in that it suppresses GnRH pulsatility, which thus inhibits LH and FSH secretion. And by doing this, it maintains lactational amenorrhea. It also promotes nurturing and caregiver behaviors and enhances social bonding, both in males and females. It also has a metabolic function, so it modulates appetite and body weight. It contributes to metabolic adaptations both during pregnancy and during lactation. And then we are learning that it has an immune modulation effect as well. So prolactin receptors are expressed on immune cells. And so we think that it may play a role in autoimmune diseases as well. So things that can increase prolactin, so suckling, nipple stimulation, pregnancy and estrogen, sleep, stress. So I know a lot of times we may see mild elevations in prolactin in individuals who are really stressed with lab draws. Dopamine receptor antagonists, we see that quite a bit in pediatrics. Primary hypothyroidism, so if you have significantly elevated TRH, it can also stimulate prolactin release. And then renal failure and cirrhosis. And then prolactin can be decreased by dopamine and dopamine agonists, which makes sense. That's what we use to treat prolactinomas, L-DOPA, and then somatostatin. All right, so we talked about all those. So we'll talk about AVP. It's our last hormone to talk about. So arginine vasopressin, or antidiuretic hormone, is made in the paraventricular nucleus and the supraoptic nucleus of the hypothalamus. And then it's released from the posterior pituitary gland. It's released along with copeptin, and its stimuli for release can be osmotic or non-osmotic. So osmotic stimuli refers to an increased plasma osmolality, and this is detected by the osmoreceptors in the hypothalamus. Non-osmotic stimuli refers to decreased arterial blood volume, so hypovolemia, hypotension, and this is detected by baroreceptors. Other things such as stress, nausea, pain, hypoglycemia can also stimulate ADP release. It has quite a few functions. So its main function is for water balance. This is via the V2 receptors in the kidney. So it stimulates it binds to those receptors and ultimately leads to the aquaporin 2 channels translocating from the intracellular vesicles to the apical membrane. This leads to increased water permeability, which leads to water reabsorption and ultimately concentrated urine. So our ultimate result is decreased plasma osmolality. It also is important for vasoconstriction, and this is via the V1A receptors. So it helps contract vascular smooth muscle. It increases systemic vascular resistance, and by doing so contributes to blood pressure regulation, especially in times of stress and shock. It also stimulates ACTH secretion from the anterior pituitary via V1B receptors. And then it has metabolic effects, and this is via the V1A receptors in the liver. So it stimulates hepatic gluconeogenesis, which contributes to glucose homeostasis. ADP is regulated by a negative feedback loop, mainly by plasma osmolality. So if you have a high plasma osmolality, you're going to release more ADP, which increases water resorption, ultimately decreasing plasma osmolality. And the opposite is true as well. If your plasma osmolality is low, you're going to decrease ADP release, decrease your water resorption, leading to dilute urine. All right. So now that we've kind of reviewed what each of these hormones does, we'll really dive into the main subjects of this talk, which is looking at the differences in these deficiencies between pediatric and adult patients. So one of the things that I think was very interesting is that there is actually a lot more overlap than we may think at first with these deficiencies, both in how they present and how we diagnose them. But where the differences really lie are in some of the nuances in presentation as well as treatment. And so we'll highlight those differences. So ACTH deficiency refers to central or secondary adrenal insufficiency, although it should be noted that central adrenal insufficiency can also refer to the hypothalamus, which is tertiary adrenal insufficiency. We typically just say central because it's extremely hard to differentiate the two, and when we're taking care of patients, it doesn't really change our treatment plan. So it refers to inadequate ACTH production from the pituitary gland, which results in cortisol deficiency with preserved aldosterone, which is an important differentiating factor from primary adrenal insufficiency. So these individuals will have hyponatremia, but will not have hyperkalemia. They will also not have hyperpigmentation, which is different from primary adrenal insufficiency. So this chart shows the clinical presentation of both pediatric and adult patients. And as you can see, there is some overlap. Pediatric patients, one of the features that we may see is growth failure or delayed puberty. We may also notice developmental delays, irritability, behavior changes. They are also at higher risk for seizures and severe hypoglycemia, especially in neonates because they cannot communicate that they're nauseous, they're not feeling good, things like that. In adult patients, and I would say in older adolescents as well, they're more likely going to present with those traditional symptoms we think of, such as fatigue, weakness, nausea, vomiting, weight loss. Adults can also present with orthostatic hypertension, depression. They can also present with hypoglycemia, but typically it's not as severe as in pediatric patients. Yeah, of course.
Should that be hypertension?
It should. I think so. Yes. Yeah. Yeah. Yeah, thank you. All right, so I would be remiss if we didn't mention adrenal crisis when we're talking about ACTH deficiency. So this is a life-threatening emergency precipitated by stress, whether that's infection, surgery, trauma. Symptoms include nausea, vomiting. There are other symptoms, and here severe hypotension, so shock. The important thing in ACTH deficiency is that aldosterone is preserved. So often we have a less severe volume depletion. So adrenal crisis is less common in these cases, but it can occur. It can be fatal, and important for us to be on the lookout for that. So ACTH deficiency diagnosis is very common between pediatric and adult patients. So sometimes we check a morning cortisol, and that could be low or inappropriately normal in this situation. ACTH level is typically low or low normal. DHEAS is low. Again, we'll have the hyponatremia without hyperkalemia, and then your aldosterone and renin will be normal. To truly diagnose this, we do an ACTH stimulation test. But it is important to note that it's only valid 2 to 4 weeks after ACTH deficiency onset. And this is because ACTH maintains adrenal cortex integrity. And so the adrenal glands are still responsive within those first few weeks of the ACTH deficiency starting. So sometimes we have to wait a few weeks before we can truly evaluate. Especially in settings such as traumatic brain injury, pituitary surgery, and of course, in the setting of steroids. I think the important thing to note is that if we have a high concern and we can't diagnose it, treat and figure it out later. There also is an insulin tolerance test that can be used to evaluate the HPA axis. Basically, with this, you use insulin to induce hypoglycemia and then measure the cortisol level. We do not use this in pediatrics due to the high risk. I'm honestly, based on what I read, I don't think it's used very much in the adult world either. But they use it in some, they've used it in some studies in the past, I think, more than anything. And then we also want to evaluate for other pituitary deficiencies. In pediatrics, we often will think about genetic testing, and then both in pediatrics and adults, looking at the brain or the pituitary for structural abnormalities. In pediatrics, we're often looking for like optic nerve hypoplasia or central line defects. So for treatment, this is where it differs between pediatrics and adults. So in pediatrics, we use hydrocortisone, 8 to 10 mg per meter squared per day, divided 3 times a day. We use hydrocortisone because it has a shorter half-life and it mimics the physiology. And so we found that this helps promote appropriate linear growth in our patients. We monitor growth velocity very closely because if we see that growth velocity is slowing down, that's a sign that we are possibly over-treating them. And we adjust doses with growth and puberty, so it's not uncommon as kids grow for them, and especially through puberty, to need higher doses of steroids. And then in adult patients, the dosing is not based on body surface area, but more of a set dose per day. So from the literature that I was reading, typically hydrocortisone, 15 to 25 milligrams a day, often divided in like a larger dose in the morning and a smaller dose in the evening or afternoon. And then, or sometimes using prednisone, either once a day or twice a day. And then, of course, for both patient populations, we're going to monitor for signs of over and under replacement by monitoring blood pressure, monitoring growth, monitoring energy levels, things along those lines. And then stress dosing is important for both patient populations. So again, in pediatrics, we dose stress dosing based on body surface area. So for minor events, we use hydrocortisone 30 to 35 mg per meter squared per day. For major events, we'll do 50 mg per meter squared for a loading dose, and then followed by 50 mg per meter squared per day, divided Q6 for at least 24 hours. In adults, it's more of a set dose. We give 100 milligrams for IV hydrocortisone for major events, followed by 50. And then for minor events, doubling the dose is typically what's recommended. So an important point when we're talking about these hormones is that glucocorticoid replacement must be started before thyroid hormone or growth hormone therapy in patients with multiple pituitary hormone deficiencies. And this is because both growth hormone and thyroid hormone will accelerate cortisol metabolism and can precipitate an adrenal crisis. And so it's important for us to explain this to our patients and to be suspicious of ACTH deficiency when we find another central hormone deficiency. All right, any questions about ACTH before we move on to TSH? All right, so TSH deficiency, again, has a lot of common presenting features between pediatric and adult patients. So we traditionally think of, low energy, dry skin, hair loss, constipation, cold intolerance. Dyslipidemia can also be a presenting factor both in pediatric and adult patients. For pediatric patients specifically, growth impairment and delayed growth is something that we often see, especially in severe cases. You may see poor school performance or developmental delays, or families may mention like their kids a lot quieter than they used to be, things like that. They may have pubertal delays, and actually in severe cases, you can have precocious puberty. In adults, they can have cognitive impairment, so like memory loss, trouble concentrating. They can also have reproductive abnormalities. So females may see menstrual irregularities. They may have trouble with infertility or decreased libido. So for diagnosis, you'll find a low free T4 with inappropriately normal or low TSH. It's important to get an MRI of the brain or pituitary to look for mass lesions, especially if TSH is in general, it's important to look for that. You want to also screen for other pituitary hormone deficiencies, and then look at medications that could interfere with labs and or alter thyroid function itself, because that can definitely be playing a role in the labs that you're seeing. And then, especially in newborns, early diagnosis is very important and essential to prevent irreversible neurodevelopmental delays. So we have our newborn screens, which screen for congenital hypothyroidism. If the primary testing is T4 based, then we will detect most cases of central hypothyroidism. But if the primary program is TSH based, where we check a TSH with a reflex T4, then some of these cases may be missed. And so it's important to just have a high clinical suspicion. So treatment, the biggest difference in pediatrics versus adults is that in pediatrics, again, we are age and weight based, whereas adults are more of a set dose per day. We also, in pediatrics, we use higher doses than adults. You need more thyroid hormone earlier in life than you do later in life. And that goes back to the importance of thyroid hormone in brain development, especially in the first 3 years of life. So for newborns, we start off at a pretty high dose, 10 to 15 mics per kg per day. And then you can see as you get older, your thyroid hormone needs decrease until eventually you're at the adult thyroid hormone needs. For adults, especially the elderly and those with cardiac disease, it's recommended to start at lower doses to prevent any side effects or complications. And it's important in long-standing hypothyroidism to titrate the dose very slowly. In pediatrics, this is important because if we correct the thyroid level is too fast, we can lead to advanced bone age or quickly maturing bone age, which could affect their adult height. So we monitor that closely. And in TSH deficiency, free T4 is really the only thing we need to monitor because we know the TSH is not going to be accurate. And so in kids, we monitor thyroid levels pretty frequently because they are growing so much. So in newborns, we monitor thyroid labs every month until they're about 6 months old. Then we do it about every 2 months. And then from 1 to 3 years, usually it's about every 2 to 3 months. And then throughout the rest of childhood, it's traditionally about every 6 months while they're still growing. Once you are done growing, then you can check thyroid labs about once a year. For both patient populations, the main goal is to maintain euthyroidism. For pediatrics, we are more focused on linear growth and development, whereas for adults, the focus is on symptom relief, which makes sense because you're no longer growing taller. So, but especially for our younger kids, focusing on development is very important. All right, so moving on to growth hormone deficiency. So the main features, as you would expect in pediatrics, is that we have an impaired linear growth or growth failure, short stature. A lot of times these kids look a lot younger than their actual age. In adults, the main things they may present with is more metabolic dysfunction. So low energy, decreased quality of life, things along those lines. Both populations can present with decreased lean muscle mass and central obesity. In kids, they often have, like they don't have problems gaining weight. So they're, a little pudgier but shorter type of picture. For pediatric patients, we often see a delayed bone age and also delayed dentition, which is why we ask about when they got their first tooth and when they lost their first tooth. So a lot of times they'll lose teeth late. In adults, they may have low bone mineral density. Neonates are interesting in that they can present with other things we don't traditionally see in older kids. So they can present with hypoglycemia, jaundice, micropenis, central incisor. And so those are things that we may be called about in the newborn nursery. And then adult patients can present with dyslipidemia, reduced left ventricular function, reduced exercise capacity, as well as mood changes and things along those lines. So for diagnosis, a random growth hormone level is not useful in any patient population, and this is because of the pulsatile secretion of growth hormone. IGF-1 levels are good screening tools, but they're not enough for diagnosis or exclusion. So you have to put it with your clinical picture. And we may not require stimulation testing if the patient has known pituitary dysfunction with a high clinical suspicion. So particularly in pediatrics, if you have 2 or more pituitary hormones and you have decreasing growth velocity, low or low normal IGF-1, a lot of times those kids do not need stimulation testing to qualify for growth hormone. And from what I read, that can also be similar in adults, although most of the things I read said that it's usually 3 or more pituitary hormone deficiencies in order to qualify without a stimulation test. So when do we test? I think this kind of is self-explanatory, short stature, poor growth velocity, not growing where they should for their genetics. In adults, we test if there's evidence of pituitary or paracellular pathology, or if they've had a hypothalamic pituitary insult. It's also important to note that we must retest childhood onset growth hormone deficiency. And this doesn't necessarily mean we have to do a stimulation test in these individuals, but we need to be checking growth factors once they are done with linear growth to make sure that they have enough growth hormone to function as an adult. Over 50% of individuals with childhood growth hormone deficiency will normalize, especially if they don't have any pituitary structural abnormalities. But it is important to check growth factors after we are off treatment for a few months. So in kids, we check IGF-BP3 as well as IGF-1. And this is because IGF-1 alone can be misleading in younger children, especially kids younger than 2. IGF-BP3, as you get older, is not quite as helpful as it is in that younger age group. For provocative testing in pediatrics, we use arginine, clonidine, or glucagon. You have to fail 2 out of the 3 in order to have the diagnosis, and we look for a peak growth hormone less than 10. In adults, the criteria are stricter, which makes sense because you don't need as much growth hormone as an adult as you do as a child, and so the peak growth hormone has to be less than 5. Insulin is often referred to as the gold standard for growth hormone deficiency diagnosis, but in the literature and things like that, but we do not use this, especially in pediatrics, due to the risk of severe hypoglycemia. But that is out there in the literature. All right, so treatment. So our goals are very different in pediatric and adult patients. So in pediatrics, our goals are to achieve normal final adult height and help kids reach their genetic target height. We give doses that are higher and are based on weight. Traditionally, we do 0.18 to 0.25 mg per kg per week. We do have weekly growth hormone now, so that can be given weekly or divided into 7 daily doses. For adult patients, the main goal is to reverse adverse metabolic consequences and improve quality of life. So the dosing is lower, and it's more based on age rather than weight, and which makes a lot of sense. For monitoring both age groups, we're going to monitor IGF-1 levels to make sure we're keeping their doses in a safe range. We're going to monitor thyroid labs yearly. And then for pediatrics, we're monitoring their bone age as well as their growth velocity. In adults, it's also recommended to monitor A1C and a fasting glucose because growth hormone can lead to hyperglycemia. And then also to monitor lipids because it can cause hyperlipidemia. Oh, sorry, not too fast. All right, so LH and FSH deficiency. For pediatrics, the main thing we see is absent or arrested pubertal development. Those are our big red flags. So neonates, sometimes we can have clues that this is going on, especially in males, if they have micropenis, cryptorchidism, or small testes when they're first born. For both males and females, midline defects can be a sign that we need to be monitoring for this, as well as renal agenesis, hearing loss. In older kids, anosmia can be a sign of pituitary deficiency as well in LH and FSH. In neonates, if we are concerned about this, we can get labs around 2 to 4 months of age to evaluate for the mini puberty of infancy. But we know sometimes that is difficult to do. And so sometimes this is not something we can diagnose until later in life. So adolescents, we are concerned about this if they have no testicular enlargement by 14 years old or no breast development by 13. Also primary amenorrhea, so a female who had breast development at a normal age, but it's been 4 to 5 years and she still hasn't had menses. That is concerning. And then lack of secondary sexual characteristics and anosmia as well in this patient population. For adults, the main findings that they may present with would be decreased libido. For males, erectile dysfunction. Both males and females can have trouble with fertility. Males may also notice decreased muscle mass and strength, decreased body and facial hair, gynecomastia. For females, secondary amenorrhea is also a big clinical presentation finding. And then both males and females can have decreased bone mineral density, lower energy and motivation, and increased cardiovascular risk. So to diagnose LH and FSH deficiency, you may see low or prepubertal testosterone or estradiol. You'll have low or inappropriately normal LH and FSH, and inhibin B and AMH may or may not be low, may be normal. They are not always very helpful in this situation. We're going to want to check imaging, so looking at the MRI brain and pituitary to look for tumors, also to look for the olfactory bulb, aplasia or hypoplasia, concerning for Kalman syndrome. You can do olfactory testing as well to test their sense of smell. And then you want to exclude other causes. So hyperprolactinemia is something we see a decent amount. Thyroid disease can lead to LH and FSH deficiency. Other things like the athlete triad, so, excessive exercise, weight loss, stress, things along those lines, illness, opioids and steroids as well. So taking a good history is important. And then one of the challenges we face in pediatrics is distinguishing between central hypogonadotropic hypogonadism and constitutional delay of growth and puberty. Both of these diagnoses can present very similarly. They both can have prepubertal hormone levels. They both can have a delayed bone age. The biggest thing is that those with constitutional delay typically have a family history of that. And so that's often our biggest clue that is what we're looking at. So a treatment, I will preface this by saying I just touched the surface of treatment. This is very complex, but just wanted to briefly talk about it. So in pediatric patients, our main goal is to induce and progress puberty, preserve future fertility potential, and then optimize bone, metabolic, and psychological health, because it can definitely be distressing for teenagers if their friends are going through all these changes and they are not. So that's an important factor for us to take into account. For adult patients, one of the main goals is to improve libido and sexual function, induce fertility if that's desired, increase muscle mass and bone density, and then improve energy and overall well-being. For pediatric patients, it's typically recommended to start testosterone around 12 years old at a low dose and gradually increase over time. Estrogen, we typically start between 10 and 12 years old at a low dose and increase over time. We add progesterone after menses or after 2 years of estrogen treatment. For adults, testosterone is also started at a lower dose and increased over time, targeting a normal age-appropriate testosterone level. And then estrogen replacement depends on whether you're premenopausal or postmenopausal, because your goals of care are different. And then gonadotropin therapy is preferred for fertility. And I did not dive into that during this talk. I feel like that could be several talks on its own, but just something to be aware of. All right, so AVP deficiency. The main features are also common between adults and pediatrics. So we have polyuria, polydipsia, dilute urine, fatigue, and irritability. Dehydration and hyperosmolality can occur when fluid intake cannot keep up with renal losses. So a lot of times we'll see that in our neonates because they depend on liquid for their nutrition. And so we can see that dehydration occur quickly. In pediatrics, again, we can see decreased linear growth. They may present with headaches, vomiting, visual field defects, It can be hard to diagnose in younger children because they can't tell us, oh, I'm more thirsty, I'm mad because I'm thirsty, things like that. So it can be a challenge. We also have to consider behavioral things in pediatrics, behavioral polydipsia. So children getting attention from mom and dad by asking for drinks and positive reinforcement and things along those lines. For adult patients, they can present with cognitive dysfunction, and severe presentation can involve anywhere from disorientation to seizures to coma. So it can present pretty severely. So diagnosis. So a urine output of greater than 4 to 5 mLs per kg per hour in pediatrics, or greater than 3 liters per day in adults. A serum osmolality of greater than 300 with a urine osmolality of less than 300, and then a serum sodium of greater than 145. In pediatrics, the main test we use is a water deprivation test to induce hypernatremia. And then in adults, there is the hypertonic saline stimulated copeptin. So this test involves stimulating hypernatremia as well by hypertonic saline infusion, and then measuring copeptin, which is secreted with AVP, to see what that level is. Arginine stimulated copeptin is another test that can be done. You give an arginine infusion over 30 minutes and measure copeptin at baseline and then at 60 minutes. This is not something we do in pediatrics. They have been studying this to see how accurate it is. And the studies that are out there do show that it is pretty accurate. So it could potentially be something that we can do outpatient in the future. Whereas like a water deprivation test, we traditionally have to admit the children to the hospital to do that. And it's honestly a terrible test because you just feel terrible about making them not be able to drink and eat for so long. So that could be a potentially cool thing for us in the future. And then MRI, we're going to get an MRI on these patients to look for abnormal findings. Often there'll be an absent posterior pituitary bright spot and possible pituitary stalk thickening. And then treatment. So the biggest difference in treatment is in our infants. So they have obligate fluid intake for nutrition. And so this increases their risk for hyponatremia. So with these infants, we often use buccal DDAVP. And we make this by taking intranasal formulations and diluting it. We can also use subcutaneous DDAVP, but the oral DDAVP just, we can't get the doses small enough for these neonates. We also sometimes use thiazide diuretics with a low solute formula with the idea that we're delivering less concentration to the kidneys, and the thiazide diuretic helps with that as well. In both children and adults, we use oral DDAVP starting at 0.05 milligrams BID and then titrating it based on urine output and sodium levels. There also is intranasal DDAVP, although it's not used as often as it used to be. And then in kids, we often have to adjust doses as they grow. And then one challenge that I was reading about in adults is pregnancy. So if you have AVP deficiency before you're pregnant, it can be exacerbated by the increased water turnover and metabolic clearance of vasopressin during pregnancy. And then you can also get gestational DI, which is due to high levels of placental vasopressinase that degrades endogenous vasopressin. So I thought that was interesting. All right, so now we are going to the last section of this talk, transitioning from pediatric to adult care. So why is this important? So the reason this is important is because the dropout rate from clinical care is 30 to 40% among patients with chronic endocrine diseases. That's a lot of patients that that we are missing. The long-term and severe consequences may result when hormonal replacement is not maintained or adjusted during adult life. And then there are a lot of consequences of disruption of care. So we can see poor clinical results, higher hospitalization rates, and secondary diseases. So by preventative care can lead to less cost for the healthcare system as well as for the individual. And hypopituitarism in particular requires special attention because noncompliance with these hormone replacements can be life-threatening. So the most common barriers to transition is inadequate preparation and transition readiness. So patients often lack adequate disease-related knowledge, self-management skills, and understanding of their disease. And so they don't understand why they need to go to the endocrinologist every 4 to 6 months. Communication and coordination failures between providers. So a lot of these individuals with hypopituitarism don't necessarily follow the textbook. And so throughout their life, we've had to do things maybe a little differently than what the textbook says. And so it's important for us to communicate why we did X, Y, and Z so the next provider doesn't have to reinvent the wheel. And then the psychological, psychosocial, and medical challenges of just this time period in life. So this is a very vulnerable period. So, a lot of these young adults are venturing out on their own for the first time, maybe going to college or starting an adult job. You might be starting a family. So there's lots of new things. And so the idea of getting a new provider and having to do all of that can be very overwhelming. And then there, as we see often in healthcare, there are a lot of systemic healthcare barriers that can make it harder for these young adults. So lack of organizational support, lack of provider education on how to help them with that transition, lack of resources, and then financial and access barriers as well. So the transition of care timeline. So what studies have shown is that earlier initiation of transfer of care leads to better disease knowledge and self-management. So in pediatrics, we should start this planning at 11 to 13 years old. And this doesn't mean that we need to make them independent. It means that we need to continuously involve them more in their care. And so this process involves ongoing transition readiness assessments, alone time with providers to promote autonomy, and direct patient involvement in planning. So we're talking with them, not at them. We're not ignoring that they're a part of this patient care process. And then the transition to adult care typically occurs at 18 to 21 years after completion of growth and puberty. One thing I found when I was making this talk is the 6 core elements approach and timeline. And if you Google the 6 core elements of transition of care, you'll find this fantastic website that has a lot of information for providers and for patients. And I really liked this timeline that it set out to help us know what age we should be doing things. So at 12 to 14, we should be discussing what transition is going to look like, what their care is going to look like over time. Between 14 and 18, we're tracking their progress, assessing the patient's skills. So what education do they need before they're ready to transition, and then developing a healthcare treatment plan with them so that they know what their needs are when they make that transition. And then 18 to 21 is when we make that transfer of care to the adult center. And then this timeline also recommends following up with that individual so we can get feedback on how the process went to make it better for the next individual. The biggest essential components to transitioning our patients is assessing their knowledge. Because if they don't understand what their condition is, if they don't understand what their medicines are for, they're just going to say, oh, well, why am I going to take this medicine? I don't want to take this 3 times a day. But if we take the time to explain to them, what could happen if they don't take this medicine, why this is important, that helps compliance, and it helps follow up. It's also important when we are making that transition from pediatrics to adult providers that we reassess the pituitary function to reevaluate, what their needs are now that they're done growing. And I think of, in particular, in pediatrics, growth hormone. So you're done growing taller. Do you still need growth hormone as an adult? Yes or no? So we can answer that question for them. And making sure that we're not handing over, incomplete, unwrapped packages to our adult colleagues, making sure that we have those ducks in a row. And one thing that I read a lot about was joint transition clinics. So this refers to a combination team model that involves both pediatric and adult endocrinologists in this case, as well as other care providers like nurses, psychologists, maybe case managers, and it helps bridge the gap by having a shared appointment. So they see the familiar face, they meet the new face, and what they have shown is that this promotes better patient satisfaction, better follow-up, and better adherence rates as well. And I think it's important to note that when we talk about transitioning, that refers to a developmental process of gaining independence, whereas transfer refers to the actual event of changing doctors. And so the transition is gradual, whereas the transfer is a single event. And so the transition really involves more direct real-time coordination, and it's very important for these complex chronic illnesses, whereas direct transfer of care, it is less complex, and so certainly there are a lot of patients in endocrinology that this is appropriate for, like our young adults that have hypothyroidism, who are on stable doses. They don't need a long visit with an adult and pediatric endocrinologist. Those are appropriate for transfer of care. And then just to summarize the critical counseling point. So from a pediatric standpoint, it's important to inform our patients and families from the very beginning about the lifelong nature of hormone replacement therapies. And I think our group is very good about being honest with families about this when we're having these hard conversations with them. That this is a journey that we're going to be on with you for the long haul, and explaining how that's going to change as their child grows. We want to make sure they understand that completing growth and puberty doesn't mean that we're done with these hormones. It doesn't mean that they're physiologic and psychologically mature. And so while how we need medicines changes, we will still likely need these medicines. And then success depends on patient readiness. So we have to transition the family's role from being direct caregivers to being supporters, which can be very hard sometimes, and then helping the patient take on the role as self-manager. So empowering them to take care of their own health so they can be successful adults moving forward. All right, so I like this quote as we were talking about this fragile, sensitive time in these young adults' lives. They may forget what you said, but they will never forget how you made them feel. And so I think that's important because, they are experiencing a lot of transitions. And so being good listeners sometimes is the best thing we can offer these individuals. All right, any questions? Oh, let's see that.
Lovely, wonderful, very thorough conference talk. And I wanted to commend you, Dr. Coriell, on highlighting the importance of transition, because we can do a great job in the pediatric space and we can do a great job in the adult space. But if we can't get the kid to the adult space and help them to establish care, it doesn't matter how good of a doctor we are. So I love that you focus on that and touch that and give practical advice and recommendations that are evidence-based for how to do that. Thank you for that.
All right, here's the CME code for today.
There were a couple of questions.
Okay, I tried to get it pulled up. Let's see if I can do it. Oh. try. It's letting me hover. Oh, there we go. Okay. All right. Is oral masamorelin testing used in kiddos? No, we do not use that in kiddos. I honestly have not heard about that. So weekly growth hormone, the chat asked to share experience with weekly growth hormone. The studies have shown that it's equally effective as daily growth hormone. The side effects are very similar. I have used it a lot so far, especially in patients that have autism or developmental delays. It can be really helpful because that process can be traumatic for families to do every day. I've seen really good results so far. Though there are different brands and their dosing is very different. So Inglina is one brand and the recommended dose is 0.6 mg per kg. I got to say that raises my blood pressure every time I do that. But if you look at the study, that's what they had to use for it to be effective, and the side effects were the same. So it's safe, but so that is a difference with the long-acting growth hormone. And then someone mentioned that many academic centers have set up joint pediatric adult clinics for teenagers to facilitate the transfer. Has this been considered at UofL?
Yeah.
I think so. Yes. Yes. Dr. Folsom says yes. More to come in the future. So I thought that I know we've been working on that transition piece. We've definitely been had a program in place for our patients with diabetes, and now focusing on our patients with endocrinology or with other endocrine abnormalities as well. So yes, to more for the future.